Yes, I am beautiful. I am pretty. Thank you for acknowledging and for making me say it out loud. It's a bit weird. That's all the 190 really wants is I don't want to be sick. And if bad luck befalls me and I get sick, I can get it sorted, either for me or my child, my wife, whatever, right? That's it. Because for young people, and remember, interns are 26-year-olds, 25, 26, they're really young people who've been placed in a context that has no relationship to them except work. And it's not a problem. Yeah? This is work. Go there and do your work. But you're not working with papers and with jembes. You're working with human beings who've come to you at their most vulnerable time. And you know what to do. It's different when I don't know what to do, and what I'm supposed to do is to refer you. Yeah. But I know what to do, and if I had the things to do, like literally, we could have saved this life, this mother and baby. It's really important to repeat how disempowering that is. Not just for the doctor in that moment and for the patient, but also for the same medics when they themselves become ill. And again, Kigondo and yourself, Wangari, several medics we've lost in the same hospitals where they serve.
Hi, welcome, Karibu, to the One Health Lens podcast. I am Dr. Diana Wangari Gitau.
And I am Dr. Simon Moshara Kegodu.
On this podcast, we'll be talking about everything health, from health matters, global perspectives, and the road to universal health coverage.
Today, we will be focusing on the basics of universal health coverage, commonly termed UHC.
In the studio with us today is the lovely Wangari Nganga. Beautiful, pretty, smiling, probably the longest I've seen her smile. So, Wangari, introduce yourself.
Yes, I am beautiful. I am pretty. Thank you for acknowledging and for making me say it out loud. It's a bit weird. My name is Wangari Nganga. I am a health policy expert. I have experience here in Kenya, starting from the medical field, a medical doctor, worked in the peri-urban and rural areas of the country, moved on to policy work, and now have my wings spread internationally. I have experience across the continent and in some Asian countries as well.
Okay, lovely to have you. So maybe tell us about your experience in healthcare, working mostly in, I would say, public sector, your interaction with patients. Because when you talk about universal health coverage, eventually it comes back to the patients, right? So what's your experience like? What has your experience been like?
Yeah, I think that's a great place to start. And, I have a long-term friend here, Dr. Kigondu. I'm thinking back to me being in med school and, like the first times we're hearing these words, universal health coverage. And we are here talking about it as if it's a common term. And if I'm maybe a little bit abrasive, I feel like it's a rebranding. It's the same conversation we've been having. It's the health for all for 1978. It's what the forefathers of our country were fighting for, the time of independence for eradicating ill disease. It's just that basic. That's all the 190 really wants is I don't want to be sick. And if bad luck befalls me and I get sick, I can get it sorted, either for me or my child, my wife, whatever, right? That's it. Then the rest, as the languages that we add, the structures of policies, that really is a conversation amongst the experts. But for the patient or the patient-to-be, that's what they really want to know. And I'm thinking of myself as a med student, in the corridors of KNH, whether it's in pediatrics, in surgery, in medicine. There was no time where we were sitting down to say, what is UHC and what are we going to do about it? All we wanted to know is that has the patient been attended to? They've come to casualty, they've been seen by whoever they need to be seen to, they've gotten the medicines that they needed to get. And if they don't have, then you're over there having the conversation with the relatives about where they're going to get either the imaging, the test, the medicines, to get them sorted. And probably unbelievable to most of the public, the doctors and the nurses are not in the business of trying to keep you in hospital. Especially not in the public sector, which is what I can speak to. The quicker your turnaround time, of course with a positive outcome, is to their best interest. Because most of the time it's overcrowded, it's over, the workload is a lot. They're not trying to bring more of you in or to keep you in longer than necessary, right? So I'm thinking back to those days, and I'm thinking about my internship days and how quick, in Kigondo, I'd really love your experience. It was a bit, before me, but I remember that almost like cognitive dissonance between this is what I was taught in med school. Anyone who comes with a coma, you remember the Glasgow coma scale, of less than 8, and you help the audience translate what that means.
Yes.
But anyone who came with a coma of a certain degree needed to be in an ICU. And this is what I mean. And you had to say those things, otherwise you're getting a supplementary in surg. That was the life.
Yeah.
But then you go out there to practice, and I did my internship in what I think was one of the best internship centers at that time.
Which is?
Nyeri, PGH. Please note I'm not from Nyeri. I actually thought it was quite rural when I went there. But
Okay. Yeah.
I did internship in one of the best internship centers. And, everyone who had a coma of 3, which is like a lot worse than 8, just for the layman's understanding, were not in ICU. We were nursing them, or we were attending to them in the ward. So there's just this dissonance. Okay, anyone whose kidneys have failed basically needs to be on dialysis. So there's no dialysis center. So there's this just cognitive dissonance between this is what I was taught in med school, in the University of Nairobi, where it's global standards comparison. That time there were fewer med schools. There are many more now. We've got some of the best training in this country. It's globally recognized. So you've passed to an extent where you can work almost anywhere in the world. And then you go to practice, and it's just like...
Very different.
It's just
very different.
It's such a difference.
It is. It's, in essence, you find yourself saying that, hey, this is what I've learned, but you have to bring in these other social factors, these other financing elements, right? So if ideally you needed to get a patient, as you're saying, in ICU, yet the beds are full, what do? You're not going to send them back home. You're going to keep them in the ward. And then you have to figure it out from there. It's day-to-day figuring it out. And since Wangari has referred to you as the long-time dinosaur, who has experience. You have experience even you've had over 2 decades of experience, if not more. Maybe tell us a little bit about your experience before we take it back to universal health coverage. Your experience, what was it like?
I entered internship in the year 2000. In the year 2000, Machakos District Hospital then. And that was after 6 years of being in Kenyatta National Hospital. So Kenyatta National Hospital, as medical students, the training is really good because you have everything and you see everything.
Everyone is coming to
you rotate
KNH.
in all rotations.
Yes.
To go to Machakos, we took 4 hours. There was no road. Mombasa was one way. Is it 2-way? It's actually 2-way.
It's 2-way, yeah.
Yeah.
No.
So we took 4
You see?
we took 4 hours to go there, and it looked so far away. And therefore, of course, in the context of UHC, if you compare now when a road is tarmacked and there is access, that can point to access. Now, when we went there, that hospital had collapsed. There was nothing. I was in shock, having grown up in Nairobi for many years, where there was a functional health system. That hospital had literally collapsed.
This was the days for national, it was still national government, yeah?
In the year 2000,
Yeah,
where health was run from the Ministry of Health, so to speak, But just to fast forward, after 1 year, after we, as interns, we were interns, 5 interns actually, just after 1 year, what I can say, a new medical superintendent came, many things came, changed, the governance changed. After 1 year, the Machakos District Hospital became the hospital of choice for the people of Machakos.
Yes.
So services started being provided, the governance was good, and to date, that was the turning point, the year 2000, 2001. My second experience was when I was a medical superintendent in Isiolo District Hospital. And at that point, the year 2000 to 2013, the growth of the health system occurred because of a very good policy from the Ministry of Health called reversing the trend. What they were saying is that the trend in health was bad. There was nothing working.
We
So
need
they
to
put down
reverse
a policy, put down support supervision structure and targets, and all of a sudden the health outcomes, because they were being measured and written down, so it was a very good period. And that's the time when actually a lot of hospitals grew. A lot of internship centers were created at that time because the medical board was used in helping grow the society, and there was supervision from the Ministry of Health to the provincial level to the DMSO level, which was the zone, and it really helped. Just as an example, if we use the Isiolo District Hospital as an example, the finances grew fourfold, a turnaround from 6 million to 24 million. It became an internship center in 2 to 3 years. The services increased, and to date is an internship center. It's providing the services they never used to provide them. In the devolution era, post-devolution, there were certain things that I know a lot of issues that are spoken of in devolution, mainly human resource, may sound negative, but there is the aspect of the managed equipment schemes. And Wangari will speak to this very well, because in the context of UHC, the cost of services reduced relatively because of availability of medical equipment.
Before we go into MES, Doc, you've raised several important points that I think are just worth rehashing. One is it's the leadership issue, it's the governance issue, it's someone has to care, right? And someone has to want to do something about this, and
Absolutely.
just make that effort. And it's actually not as instinctive for medics, because the training is actually to treat. It's not to run a hospital, which is running a business.
Absolutely.
And just before I let you jump back in, there's something else you said which I think had never reconnected this dot about the policy for reversing the trend. And it's almost like religion. You have to first confess your sins. You have to first acknowledge. What do they say? Nimetubu.
Confessional.
I have to accept that I am a sinner first, right? So there has to be an acknowledgement that there's a failure in the health system, and things are trending in the wrong direction.
I like what you say. It's leadership. It's elements of first. What are the structures, right? So if I'm at the end of this and I'm listening to this, right, I've had elements of internship, I've had clinical practice translating to public sector. And perhaps just to frame that, it starts off with, yes, you want to become a doctor. And I mean, KCSE results came out, guys said, I want to be a doctor, and everyone imagines it's going to be Grey's Anatomy type, right? And typically it's the 5-6 years of education in whatever university it is. You do an internship, and that's where it gets complex, because then the internship is you have to go and literally either shadow, assist, or be the primary doctor, especially if, as Kigondo was saying, you're in Isiolo, for example, right? You are probably the primary doctor, right? So in this case, the challenges you're facing is not so much clinical, is where now you're starting to realize, oh, wait a minute, we do not have equipment for this. Yes, we need to do an X-ray, ultrasound, whatever it is, even before we go to dialysis and the rest. Such basic factors becomes something that you have to consider, even in terms of now going back to now the leadership scheme. I think then it becomes important to understand, okay, I've gotten there, I'm an intern, right? If I'm sitting on the other end, all I'm seeing is people walking around in lab coats, right? I don't know who's a superintendent. I don't know all these other things. So maybe just break it down to me to understand just that context, first of all, even before we go to the policy. What does that look like, right?
Before I describe it from the patient's eyes, I'll just take one more stab. You've said something that sparked... it's a fond memory, but it's also a little bit of a sad memory. So one of my very good friends, who'll probably be able to identify himself through this description, born and raised in Nairobi primary, Nairobi school, Nairobi university, Nairobian through and through. Then you do your internship, you finish at that time, and, in the current context, we don't take that for granted. At that time, you were posted as a medical officer. You had a job, you had the opportunity to turn it down. if you didn't want to work for government and you move on. And so he's posted in one of the more rural facilities. It's we call them glorified health centers.
Okay.
It's the label, or rather the what do you call it? The facility title, like level 3, 2, 3, you know, that the label doesn't match the services that are available. So you're there. You've done all the things you are supposed to do, right? You've done your medicine, you've passed. You've done your internship, you've been certified by the Kenya Medical Practitioners and Dentists at that time board, now council, as a certified doctor. I am there. And then you've come, Wangari, you're the patient. You've had, this is your third pregnancy. The other 2 were delivery by cesarean section. So for us who are medics, that is an automatic cesarean section when you're term. I know what to do, and you have come. But I don't have anything to do what I'm supposed to do. I think it's really important to underscore that, because for young people, and remember, interns are 26-year-olds, 25, 26, they're really young people who've been placed in a context that has no relationship to them except work, and it's not a problem. This is work. Go there and do your work. But you're not working with papers and with jembes. You're working with human beings who've come to you at their most vulnerable time, and you know what to do. You know, it's different when I don't know what to do, and what I'm supposed to do is to refer you. But I know what to do, and if I had the things to do, like literally, we could have saved this life, this mother and baby. It's really important to repeat how disempowering that is, not just for the doctor in that moment and for the patient, but also for the same medics when they themselves become ill. And again, Kigondo and yourself, Wangari, you know, several medics we've lost in the same hospitals where they serve. In those hospitals, when there's no blood, even me when I'm sick, but there's nowhere. I mean, I don't have a chopper that actually I'll go to wherever. You know what the state of our medical insurance is, even as employees. So it's not that I have access. This lack of access, it's not just you over there suffering. It's not like the road situation where the road has potholes. Some people don't have cars, they walk. Me with a jalopy, then my car breaks down all the time. And then the person who's in charge of fixing the road comes with a V8 or a chopper. It's not like that. Me, I go to the same market that you go to. Ukusi kwetu bede. I didn't vote for your MP. I didn't do all those things. My children go to the school that is there. There's no option. I mean, I'm talking about, you know, are we allowed to name names? You know, like really places where there's no alternative.
Absolutely.
So it doesn't matter if you have money. You can, there's no private. Exactly.
This is where you'll go.
If I'm sick, this is the hospital I'm also using. Right?
Absolutely.
So you guys, this community that comes from here, the choices you made politically I'm also doomed or advantaged by those choices. And I think that's really important to understand. Because I think previous advocacy efforts by the health workers across the cadres have been misconstrued to be, it's about, you know, the health workers want,
they're striking because they want more money. Yet they're already doctors.
And even amongst the health workers, guys will say, you guys, we are getting confused by the message. Let's focus that this is about our welfare. But you can't disentangle. Can you use that word as well?
You cannot disassociate.
They're indivisible, right?
Absolutely.
The value I get from doing my job, especially when you're in this line of work, is not just the remuneration, the monetary compensation, the pecuniary benefits that come, right? They're non-pecuniary. I didn't come here so that you don't get better.
Absolutely.
So now I've completely not answered your question, but I think it was important to underscore that. But just I'll touch a little bit on the perspective of the patient. Patient walks in. Anyone in a white coat is a doctor. Anyone.
Absolutely.
And for those who are medics, you know, white coats are ubiquitously available.
Absolutely.
And then there's all the other perceptions that come. Depending on which part of town you are, cultural differences are a bit more overt, right? So you walk in looking as, I also didn't tell you how you're pretty.
Oh, thank you. I was waiting for that though. I was.
Looking as pretty as you are and looking like melanin does us, you know, age doesn't tell.
It doesn't.
And the patient is not, they are looking at you and asking you, Daktari ako wapi? Because it is not you.
It cannot be me.
It cannot
It
be.
cannot
It
be me.
cannot
This
be you.
young person here. Daktari, no.
It cannot be you.
And female as well
Absolutely.
sometimes.
So
No.
they are telling you, please tell Daktari, I've been here waiting for,
Yeah.
and that's the context in which you're working.
Yes.
But in those moments of vulnerability, before I'm not even going to start getting upset that you don't think I'm the doctor, that you do what you can with what you have for that patient.
Yes.
And not once or twice. Again, now I shut up for Kigondu. Not once or twice.
Yes.
You'll be paying from your pocket.
Yeah. Absolutely. Absolutely.
Because what they need is saline.
Yeah.
What they need is one injection,
Yeah.
at least till they get to the next hospital. What they need is for you to pay. Banged.
Absolutely.
What they need is for you to pay for them,
Yeah.
For that pro box to act as the ambulance,
Yes.
so that they get to the next station, so that at least the life is saved,
Yeah.
right?
Yeah.
So you do, as you said, you make do. You're over there just figuring it out.
Absolutely. And I like that, you've given us now the context of what the situation on the ground is like, right? Both patient, both provider. And now Kigondo can come in and tell us, okay, fine. With your experience, you are taking us through sort of the timeline, right? From Machakos to Isiolo, there are these different interventions. Things needed to be resuscitated at some point, right? Tell us.
Yes, it's good that Wangari got the Kutubu part, and because actually maybe it might not be easy to understand, but to say that the people at that time sat down and said, why is health the way it is? And in simple terms, they realized that the money is not being collected efficiently. The money is not being accounted for. There are no services. There is no good leadership. There is no good infrastructure, so to speak. So they sat down and put a document that measures all this. And the document had... if you go back and get a performance contract of the PS of health in 2007, was very structured. At the top there was infrastructure. And infrastructure means what? At that time, we had to get title deeds for hospitals because over time, people were eating into land of hospitals because it was public land and there was no. So that's infrastructure. That's already identifying a problem. And we saw what happened with schools in these latter years. We said, schools don't have titles. Us in health, we got our titles long time ago because there was a performance contract attached to the permanent secretary of health. The second one, and very important, was the human resources for health. That is the people working. I'll give you an example. I was assigned, one of the hospitals that I was assigned was called Mutwate. Mutwate is in Meru North.
I come from Meru, by the way. Goji. Yes.
Oh, nice. Meru North. Now, in Meru North, at that particular time, the supervision team from the big hospital, and the big hospital then was Isiolo District Hospital, we went there, administrator, accountant, and administrator, the surgeon, the pharmacist in charge, so that we can, what we were calling capacity build from the bigger zonal hospital. So we went there. We found a hospital had been promoted from a dispensary to a level 4, but had 3 nurses as the staff. Wow. And at the time we arrived in the morning at about 9 o'clock, there were 400 patients waiting. And the nurses had, what they had done over time, divided themselves.
There were no doctors, no clinical officers, there were none.
There were none at that particular time. With 400 patients. So they've divided. There's one has said they're doing mother and child. Another one is seeing, and then they're collecting money on a basket, 20 bobs. Those were there are 20 shillings. And another one is dressing wounds, and there are lines of people. So that for me was an eye-opener because the first thing the supervision team did was not to supervise, but to see the patients.
Absolutely.
So you first have to settle the patients first. So we
Absolutely.
divided
Yeah.
ourselves.
Yeah.
The pharmacist went to the pharmacy to try to manage the drugs. I started seeing patients. The surgeon saw patients. The administrator went and looked around to see what administration work, and the nursing officer in charge went to help, things like MCH. And for me, that was a big eye opener. But more importantly, after we finished seeing these patients, 400 of them, we sat down with their team. We ticked the performance contract and said, human resources, what is missing? One doctor, 2 clinical officers would probably be there, and like 10 more nurses.
And maybe just to even clarify, right? The structure is usually that when you're talking about level 1, level 2, level 2, 3, all the way, is such that it's health dispensary, medical center, district at that point in time, provincial, then the tertiary, right?
Yes.
And for all this, it was a factor of if you're dispensary versus medical center, there's certain number of staff you're meant to have, right? Whether it's the one doctor, this number of equipment, right? So that then that's where the discrepancy becomes. If you've been promoted from dispensary to medical center, essentially what that means is that it shouldn't be 3 nurses, right?
It should be resourced accordingly.
It should be resourced accordingly. Back to performance, yes.
So just to say that we used to do quarterly supervision, and after ticking that box, by the next quarter, we were discussing something else because we had posted a doctor, we had posted 2 clinical officers, and now there were 13 nurses in the facility. So now we ticked that off, and now the next thing we went to discuss is service provision. So we didn't find the 400 patients again. So that was, for me, I think that continuous, and every discussion, you sit down with the team, what are your problems? Why aren't you eradicating them? And then, and that's how between 2007 and 2013, the performance of all health facilities that had supervision improved. So there was documentation of the improvement, and there was something against which you were, and then there was support supervision all the way from the Ministry of Health, the province, because at that time there were provinces, and then the zonal, like us, we were from Isiolo, but as the crow flies, we also covered Meru North.
Of course.
It's called Meru North. So I think that starts pointing out to what universal health coverage starts getting meaning. So those 400 people who previously had no access to a doctor were now being seen by a doctor. There was a clinical officer. The nurses were doing their respectful roles, because previously the nurses now were acting doctor, acting clinical officer, acting administrator. We also installed a computer system to collect money, as opposed to one nurse collecting and putting in a basket and then buying from the same basket to refurbish.
Using, I mean, now so that I look like I actually went to school. You know what Dr. Kigondo is describing in our Kizungu Mingi, we call it performance management, right? So it's understanding that there's a cycle that needs to be followed. He's very elaborately described.
Powerful story.
A very poignant story that is just describing the 4 tenets. So one, there needs to be money at the facility. There needs to be money as cash. And there needs to be autonomy over that money. So it's useless if there's money. Money is in the bank account, right? Or whichever form it is. But I don't have autonomy over that money.
You need to call someone in Nairobi too.
Someone else needs to come and take the decision for me, the nurse in that facility, who's the one dealing with what I'm dealing with. So you need to have money at the facility, to have autonomy over that money. And then you have to have some basic management capabilities. And I'm going to say it again, because I think this is something that we've kind of missed in our pre-service training, and a little bit even in our postgraduate, whatever you're doing, a diplomas and so what, there needs to be a little bit of effort to train you with some management capability. I don't mean the theory. Again, let's not make the mistake. Well, it's not a mistake, because you need to be trained for the world. but there needs to be almost like a domestication for the context in which you work with. Some management capabilities.
At a certain point, it became that every now county needed to have 100 facilities. They all needed to have, an MRI in. They needed all these things, right? And we were saying, okay, fine. It looks very good to be ribbon cutting everywhere, but that's not how things work.
And it's like a big deal. You don't just give the expressway to someone. How do you think we should build this? No, I think we should first bring tarmac and then maybe we should bring the concrete blocks. This clearly shows you how I did not do well in physics. But you get the point, eh?
Yes.
It's not just opinions that we are throwing around.
Absolutely.
Everyone else, and maybe we should take the backstops with us, yeah? Because we are the experts in the health sector. Maybe we need to take a little bit more charge and put our narrative out there and make sure that it's drowning out every other probably uninformed opinion. Yeah. Right, so that we are setting the pace, because who else's job is that, right? So that you're saying that there is a science, and that is the work. You ask that question, what is universal health coverage? It is, when you listen to the scholars, they'll tell you it is a journey, it's not an event.
Absolutely.
What that means is that you're always recalibrating.
Absolutely.
Always from today in perpetuity. And if you look at those in the world that we say have achieved, they've not reached anywhere. Today, they are recalibrating. They're recalibrating how they buy medicines. They're negotiating directly with pharma companies. They're saying, okay, me as a country, I have 40% of my population are diabetics. I've gone to X pharmaceutical, I've gone to the other one, I've gone to the other one.
Thank you for not mentioning the names.
I've done well.
You've done too well.
And I'm negotiating. And I'm saying, by the way, if you're not going to sell to me at this price, you're not selling in this country. Not because I am Gava or I am responsible for the health within my all my borders. Whether it is run by the public sector.
Or the private. It's as long as I walk into a facility.
Absolutely. I am responsible for the quality of care that you get there. So it really has to be, we start with confessing, and then you realize whether there's no one else to do that work except you.
There's this idea that now that we have rolled out, and even rolled out in itself, universal health coverage, what it should mean is I should walk in, get my services for free. So the first thing people think is that cost, right? They're not thinking beyond that. It's not going to happen in one go. It's a process whereby we're looking at the healthcare workers, we're looking at the equipment, we're looking at the running of the system. And all this is informed by data, right? It's a fact that, and this I think was also the genesis of sort of the devolution in healthcare, was that if, for example, in northeastern counties, snake bites are more prevalent than, for example, diabetes in central, then of course what you have in the different counties is very different. Absolutely. But there's a science behind it of saying that how are we going to first get the resources that we need? How are we going to provide an optimal working condition for it? How are we going to finance it? And how are we going to ensure this cycle keeps running? And occasionally, as you're saying with the example of Brazil, Pakistan, right, is that yes, sure, maybe diabetes was the issue 5 years ago, but right now we're seeing a reemergence of XYZ, right? Maybe right now we're talking about malaria, but in a few years we're not talking about malaria. Absolutely. And we need to change that and say, have a conversation and say, hey, now that we're now not looking at malaria, we need cheaper drugs for this. But it's beyond that. It's a component. The different pieces make a sum of the whole. It's not just one thing, right? Going back to Kigondo, right? And I like what Wangari is saying, that, there's the recalibration, but then maybe talk from your end, from your perspective, right? If you're talking about from a leadership and a governance perspective, right? And especially being, with experience of, and we'll bring it back to Wangari having worked in government before. But from that leadership governance, right? Because all that, as she said, it's not opinion leaders, right? It's science. Where are we missing? Where is that gap?
As we put it, we need to define what we want. And Wangari put it very well in terms of making the expressway. You don't give people who have suggestions of how to make the expressway. I like that example. And therefore, in health, you don't give people who have no, so to speak, expertise in the field. And the expertise can only come to the people who have been in health or are affected by health, so to speak. So if we go back to what the definition of universal health coverage is universal would mean that all people then have access. Access has many meanings to it, to the full range of quality health services. That's a very deep statement, so to speak, that they need when they need it, where they need it, and then we now come to the costing part of it without financial hardship. So that is generally how UHC is broken down. So it essentially covers the full continuum of essential health services, literally, which come from health promotion to prevention to treatment to rehabilitation to palliative care. You see. And just picking from, again, where I was, when I was medical superintendent in Isiolo District Hospital, we worked hand in hand with the medical officer of health. That was the terminology of now the medical officer who was in charge of the dispensaries and out there in the community. Those are the days, by the way. So the MOH in this day and era would be the one responsible for the CHPs, so to speak, now. You get. So they were well coordinated at those levels and all reported to the main facility. But when a mother in a dispensary had, for instance, convulsions and she's pregnant and needed to come to hospital, so the medical officer of health would liaise with the treatment team, and they would bring her from wherever she was, or we would send an ambulance and bring them. And that's how health operated. Health is not either preventive or treatment.
Absolutely.
Which is one of the where we are going wrong, so to speak. So even if you want to do prevention, someone with diabetes needs treatment. So you cannot say now let's prevent, yet the conditions are already there. You can work towards minimizing disease, meaning with the time, let's say we want to say that with time we want to reduce the incidences of these diseases, but you have to treat them, but that does not come at the expense of prevention and vice versa. So I think what we need now in terms of thinking is we need to have the right people in leadership. We have been there. I think I was the right person at that time. The reason the then director of medical services made me a medical superintendent is because I was the only consultant in that hospital at that time. So I mean, the highest person who is a medic is automatically, as in it doesn't come with thinking, unlike nowadays where people think that any Tom, Dick and Harry can run a hospital or run a big health facility. So already that is we may need to go back to that kind of things model which I think traditional medical thinking, so to speak, with respect to hierarchy was very important.
Medicine is an apprenticeship training that does not end in school. It continues. And the redistribution or the breakdown of the structure that existed before has meant that we've lost that part of the continuous medical education. The one of the magic two things, and I promise I'll summarize. And I'll call them magic, but I'm sure it was deliberate. Of the managed equipment service. Most people don't know it's called managed equipment service. It's the dialysis that is now available at your county referral hospital. It's the X-ray machine. Some people got, some counties got mammogram machines, theater equipment, etc. Two things. One, when I went to med school, and for sure in Kigondu went, when I went to med school, if you needed dialysis, if your kidneys were fried and you needed dialysis, you had 4 options in the public sector.
Kenyatta.
4. Kenyatta, Russia, aka Kisumu,
Kisumu. Yeah.
Nakuru, Mombasa.
Okay.
If you are not in those 4, death sentence.
Yeah.
Literally. There's no other ways. If you can't get dialysis, you can imagine you're not getting a kidney transplant. So the few who could raise resources went. And one of the, he's now late, one of the famous politicians then was known to have bought a dialysis machine and installed it in his house. It was a death sentence.
Yeah.
Courtesy of the MES program, there are at least 49 running. There are many other political issues, but there are 49 running in public hospitals. The second magic that happened at the same time, that's going to exemplify the point, was the intervention at NHIF then to make sure that NHIF is covering the cost of this new service. And what that did is that it introduced the service, but also capped the price.
Yeah.
I'll give you an example. An MRI image done, most people know what an MRI is, done anywhere in this country, whether it is done in a public hospital, it is done in a private hospital, will be at base 16,000 shillings, and then we go up from there if you're doing multiple. Yeah. In South Africa, it is 120,000 shillings.
Oh, really?
Because it was unchecked through this fight. This is the role of government. You're a referee for the entire sector, not just the public sector. And because of this intervention of the health financing of these services, the dialysis centers are actually 1,800 in the country. Because the private sector was welcome to play, but they're welcome to play, and here are the rules. And the rules were fair enough, like that they can do their business,
play.
But we've increased access, right? So what is UHC? UHC has some story to do with access, which I've just described. It's financial. It's the road that now doesn't take 4 hours from Nairobi. It's all those things. It's financial access. It's physical access. It's cultural access. It's all of those barriers broken down. Yeah. It's quality. What does quality mean? It means that you have the right complement of health workers, but that they are also doing the right thing at the right time. It doesn't matter if they do it 2 hours later. It doesn't matter. It has to be the same military precision. Otherwise, the life is gone.
Absolutely.
And it's something to do with financial hardship. And I am stopping. You asked me what UHC is.
It is.
It's access, it's quality, it's financial protection.
Absolutely. I mean, it sounds like there's a lot to unpack, right? We started off by saying these are just the basics, right? This is laying out the context that there's a lot we have to talk about. Private sector, you've said, equipment, health workers, financing. In fact, what does financing really look like, right? There's all this. And I think that's part of the value of these conversations, but also a lot of what we're going to be covering in the One Health Lens podcast. Unless Dr. Kigondu has parting shots. Very short.
Yeah, we as health workers have been very technical in the past. So we are now starting a series where we make things understandable. Put things in context so that when we are asking about health, we are not using big words, but where the layman can understand.
I think it's important. Certainly the fact that we're having 3 doctors around the table is... It is. But thank you for tuning in to the One Health Lens podcast. Join us next time as we embark on this journey on the road to universal health coverage.